These abnormalities of the flow of the blood are known as hemodynamic disorders. Hem meaning the blood, dynamics meaning the movement. So these hemodynamic disturbances or disorders include edema, hyperemia, congestion, hemorrhage, shock, etc. Today we will be taking up edema, and then after defining it, we will differentiate the various types of fluid accumulations that take place in edema, list the causes of edema, discussing the pathophysiology, morphology, and the clinical features of edema. Then we will take up hyperemia and congestion, discussing the examples of acute and chronic congestion. Edema is defined as the excessive accumulation of fluid in the interstitial spaces and the body cavities. Normally also a little bit of fluid is present in the interstitium, but when the accumulation is in excess, then the condition would be called as edema. Recalling from your knowledge of physiology, you will probably remember that there are two main forces which are acting on blood circulating within the blood vessels. These are the hydrostatic pressure and the plasma-osmotic pressure. Hydrostatic pressure is the pressure of the fluid within a confined space, in this case the blood vessels, which tends to push the fluid out of the vessel. And the plasma-oncotic pressure or plasma-osmotic pressure is the pressure which is exerted by the osmotic contents, by the colloidal contents of the blood, that is mostly the albumin, and it tends to pull back the fluids from the interstitium into the blood vessels. So here in the diagram we can see, if we consider that this is a capillary, this is the arteriolar end and this is the venular end. At the arteriolar end, the hydrostatic pressure is more than the plasma-osmotic pressure, and therefore it tends to push out the fluid into the interstitium. As it moves, as the blood flows within the capillary and a lot of fluid has been pushed out, the colloidal tissue, colloidal element increases at the venular end and thereby exerts an increased osmotic pressure, and hence the fluid which had been pushed out at the arteriolar end is pulled back by the increased osmotic pressure at the venular end. Little bit which is left behind is drained by the lymphatics, and via these lymphatics it is carried back to the blood vessels through the thoracic duct. So here again we can see that if this is a capillary, arteriolar end and the venular end, at the arteriolar end, due to net increase in the hydrostatic pressure, fluid is moving out into the interstitium. At the venular end, it is being pulled back because of the increased plasma colloid osmotic pressure. Little bit which is left behind is drained by the lymphatics, and this again is brought back to the blood vasculature via the thoracic duct. If for some reason the interstitium accumulates excess of fluid, then this condition will be called as edema. So what are the conditions which can lead to excessive accumulation of fluid in the interstitium? There could be an increase in the hydrostatic pressure, there could be a decrease in the plasma-osmotic pressure, or there could be an obstruction to the lymphatic drainage. Besides this, another condition is where there is increased permeability of the capillary vasculature, and this is mostly encountered in cases of inflammation. So, this is a situation where there is inflammatory edema, where there is increased permeability of the endothelium, and these three situations are where there is non-inflammatory edema, where the causes would be differences in the forces acting on the blood and due to abnormalities or blockage in the lymphatics. Edema may be considered local if it is confined to a small region, or generalized when it is present all over the body. This generalized edema is also called as anasarca and is mostly due to some systemic diseases. Accumulation of fluid in the interstitium is mostly encountered in the subcutaneous tissue, and that too is affected by the gravity and accumulates in the dependent portions of the body. Most of the times when the patient is mobile and standing, then this fluid tends to accumulate in the feet of the patient or ankles, and as it increases, it goes on and moves upwards. This form of edema is known as dependent edema, which is more evident in the feet and is known as pedal edema at times. Then, but in situations where the patient is recumbent and due to some other comorbidities he is not able to get up, then in such cases the dependent portion is going to be the sacrum, and then the edema fluid, if it's present, it would collect in the sacrum. This is known as sacral edema. This is a picture which is showing you a close-up view of a foot. This is the heel of the foot. What can you see? You can see a expanded or swollen area here and a small depression here. This swollen area is due to accumulation of excessive fluid, and it is known as edema. We can see this because when we put pressure on the swollen area, then due to the pressure, there is displacement of fluid, and this displacement leaves behind a depression. This depression is known as the pit, and therefore this edema is also known as pitting edema. Here also you can see that this is the foot of the patient and this is the shin. Since the edema has increased, it has moved upwards and involved the shin as well, and you can see a number of pits when we put pressure on this edema fluid. Again, this is a very swollen feet. These are very swollen feet, and here you can see that these pressure areas have produced pits on the surface, showing that this swelling is due to collection of fluid which was displaced when there was pressure put on this swollen area. Now, if for some reason the serosal surfaces of the body are involved, then there is accumulation of fluid in the body cavities. The fluid accumulation in the body cavities is given the name of effusion. If the effusion, or if there is excessive accumulation within the pleural cavity, it is called as hydrothorax. If the excessive accumulation takes place in the peritoneal cavity, it is known as hydroperitoneum, or more commonly ascites. And if it's in the pericardial cavity, it is known as hydropericardium. This here is an example of ascites, where you can see that the patient is thin and lean, but the abdomen is quite swollen, and there are certain tests which may be done to confirm that this extrusion or protrusion is due to accumulation of fluid. The tests commonly are shifting dullness, and then another feature of this edema that we should consider is the type of fluid that accumulates. The fluid that accumulates may be transudate or may be exudate. I hope you recall that transudate is a non-inflammatory fluid which is derived from due to increased hydrostatic pressure or decreased plasma osmotic pressure. It is low in proteins, and therefore the specific gravity is also low, that is less than 1.012, and usually it is straw colored. The exudate is a fluid which is derived because of increased permeability of the endothelial cells, as may be seen in cases of inflammation. It has very high protein content and therefore a higher specific gravity of more than 1.020, and it is usually cloudy in nature because of the presence of WBCs. Coming to the pathophysiology of edema, we know that the excessive fluid present in the interstitium may be derived due to increased capillary hydrostatic pressure, which may be encountered in cases of cardiac failure, or it may be seen in cases of decreased plasma osmotic pressure, and this decreased plasma osmotic pressure may be due to decreased protein content, as decreased either due to decreased formation of proteins or excessive loss of proteins. Another cause could be increased capillary permeability, as we have already discussed, which may be present in cases of inflammation, and lymphatic obstruction can also lead to the development of edema. The common causes which lead to generalized edema may be heart failure with increased hydrostatic pressure as the main component, cirrhotic liver with decreased formation of proteins and hence decreased plasma colloid osmotic pressure, nephrotic syndrome with increased loss of proteins leading to again decreased colloid osmotic pressure, renal diseases where there is mostly retention of salt with accompanied water, and this excessive salt and water retention may contribute to the excessive accumulation of fluid in the interstitial spaces. And then lastly, lymphatic obstruction leading to lymphatic edema. Considering the first factor, that is increased capillary hydrostatic pressure, it may be localized when there is deep vein thrombosis. What is thrombosis? Thrombosis is intravascular clot formation, and then there are certain situations we will be studying in the probably upcoming lectures about thrombosis, but just a brief introduction would be that at times, due to immobility, due to increased coagulation capacity of the blood, etc., there might be thrombosis or clot formation within the flowing circulation. And when this occurs, a common situation is with certain comorbidities, it may be encountered in the deep veins of the leg. When thrombosis or intravascular clot formation is encountered in the deep veins of the leg, what would happen? Obviously, the blood flow or this will be obstructed, and because of the obstruction in the blood flow which is coming up, the back pressure would increase. Therefore, thereby the hydrostatic pressure is increased and more of fluid will move out into the interstitial spaces, creating a localized type of edema prior to the thrombotic obstruction. Then another case, in another situation, generalized edema may be encountered due to increased capillary hydrostatic pressure, and the good example for which would be congestive heart failure. Now, what happens in heart failure? In heart failure, the heart is unable to contract properly and eject the amount required in the normal situations. So, there starts to be an accumulation of blood behind the heart. Suppose it's the left heart which is failing, then obviously the blood comes to the left heart from the lungs, and therefore there would be damming up of blood in the lungs. And if it's the right heart that is failing, then there would be damming up of blood in the systemic circulation, which brings back the blood to the heart, because the heart is now unable to effectively pump out the blood, and this blood which starts to dam up behind the heart now. So Here we have when the cardiac output is decreased. In cases of congestive heart failure, as I told you, their efficient contractions are not there, and the required amount of blood is not being ejected with each contraction of the heart. Hence, the cardiac output decreases. When the cardiac output decreases, the renal perfusion is also decreased. The blood going to the kidneys is decreased. When the renal perfusion is decreased, there is a system in the body whereby substance renin is activated, and renin angiotensin aldosterone axis is activated rather. And the function of this renin angiotensin aldosterone axis is to retain the blood, retain the fluid from being expressed out or excreted in the urine. And with this decreased excretion of fluid in the form of urine, more fluid is retained and the blood volume increases. This increased blood volume plus the failing heart now would increase again the hydrostatic pressure, resulting in edema, increased edema fluid. This can be easily seen in this diagram, where we can see that whenever there is hypoperfusion of the kidneys, it will give rise to the renin-angiotensin axis activation. That is, renin plus angiotensin gives rise to angiotensin 1, and this angiotensin 1 is transformed into angiotensin 2. Angiotensin 2 can cause peripheral vasoconstriction, and with this there will be increased afterload, and obviously when afterload is more, there will be decreased cardiac output. When the afterload, that is the amount of fluid beyond the heart, is more, then the heart will not be able to pump the blood efficiently into the circulation, and the cardiac output will decrease. Another important effect of angiotensin 2 is that it causes aldosterone secretion. The effect of aldosterone secretion is to retain salt and with accompanied water. This will contribute to edema and also increase the plasma volume, and hence increase the preload, that is the amount of fluid or blood before it enters the heart. So there is increased afterload, increased preload. Increased afterload causes decreased cardiac output, whereas increased preload would cause the heart to increase its contraction, and there will be more workload on the heart to perform. Both these features, the decreased cardiac output as well as the increased workload on the heart, which would combine and result in heart failure. So they both contribute to the failing heart. Now this is again the same thing, where almost the same thing, where this heart failure with decreased cardiac output would definitely lead to decreased blood volume. Decreased blood volume again would activate the renin angiotensin aldosterone axis, causing increased plasma volume. With increased plasma volume, there will be more effusion, more extrusion of the blood into the tissue spaces, and resulting in excessive accumulation, that is edema. That was the first instance where there was increased hydrostatic pressure. Now another pathophysiological state would be, as I told you, when the plasma osmotic pressure is decreased. This can occur when there is reduced albumin synthesis or increased protein loss. The cases where excessive protein loss occurs are the nephrotic syndrome, which is a common finding especially in the diabetics, or certain protein losing enteropathies. And decreased synthesis of protein, especially the albumin, takes place whenever there is liver cirrhosis or in cases of malnutrition. Both these situations will again lead to the activation of renin-angiotensin-aldosterone excess with salt and water retention, and so this salt and water retention with decreased proteins again worsens the edema. Third situation would be that of lymphatic obstruction. In cases of lymphatic obstruction, we see that mostly it is responsible for draining the little bit of fluid which is left behind at the interstitium. And for some reason, if these lymphatics are obstructed, which may occur in certain inflammatory or neoplastic or even post-surgical or post-radiation conditions, then this little bit of fluid drained by the lymphatics will not be drained back and would accumulate in the interstitium, leading to again edema formation. A slight difference, or rather a very important difference here, is that this type of edema, which is due to lymphatic obstruction, is a non-pitting edema. That is, even if you put pressure on this swollen area, no pit is formed. The conditions where lymphatic obstruction is commonly encountered are infectious states like the filarial infection, microfilari, and these filari are the larvae of these microfilari. They go and they lodge up in the lymphatics and thereby block the lymphatics. With the blockage in the lymphatics, the fluid beyond, rather prior to that drainage area is unable to be drained and it accumulates. This accumulation leads to swelling or edema, which may be so much so, especially this occurs in the lower limbs, and which increase hugely in size, so much so that the condition resembles elephantiasis. The legs become very, very heavy and enlarged and swollen, resembling elephant legs, and therefore the condition may be called as elephantiasis. Then other situation where lymphatic obstruction takes place is tumorous condition, or the tumorous condition, especially the breast tumors, where there is, when axillary clearance is done along with the mastectomy, there is fibrosis in that area and obstruction of the lymphatics takes place. So in a post-surgical, post-mastectomy situation, there might be lymphatic obstruction again. Or sometimes the lymphatics are blocked by the external pressure due to some tumor or something, then again this may lead to this may lead to accumulation of lymphatic fluid in the interstitium, and this will result in non-pitting sort of edema. When this lymphatic fluid accumulates in the body cavities, then these effusions are known as chylous infusions. Chylous because they are lymphatic. So this here is chylous effusion seen in the peritoneum. These are the loops of the gut, and this is the peritoneum that has been cut open, and within the peritoneum there was a chylous or effusion of the lymphatic fluid. Another situation could be retention of sodium with complementary retention of water. Mostly this situation is seen in cases of renal failure or renal abnormalities, and it may contribute to the increased hydrostatic and decreased osmotic pressure conditions and lead to formation of edema. Briefly, once again, we will discuss the causes and the pathophysiology together. You know that fluid edema occurs when more fluid leaves the capillaries, then it enters back. It may be encountered in situations of where increased hydrostatic pressure in the vessels, where whenever there is generalized edema, there could be congestive cardiac failure, and if it's the right-sided failure, then the preload is present in the lungs and it increases, leaving behind pulmonary edema. And if it's the right-sided heart failure, then the preload is on the systemic circulation, and the edema fluid is mostly accumulated in the subcutaneous tissues, and especially occurring in the dependent portions of the body, that is the pedal edema. The second situation could be decreased plasma oncotic pressure, and these plasma osmotic pressure may be decreased in cases of hyperproteinemias, where there is decreased formation of proteins as in cirrhosis of liver, or increased loss of proteins as in nephrotic syndrome. Third condition could be that of increased vascular permeability, which may be encountered in cases of inflammations. Another situation would be increased sodium and water retention, which may be seen in primary renal disorders or might be seen secondarily in cases of cardiac failure. Lastly, blockage of lymphatics, can also lead to a non-pitting kind of edema. Now moving on to the morphology. Grossly, you know that there is whatever, if it's the subcutaneous tissue or it appears to be swollen, even if it involves the various organs like the lungs or the brain, etc., they appear to be swollen. Microscopically, there will be swelling of the cells as well as accumulation of there is accumulation of fluid in the interstitium, but there is some swelling of the cells as well. And this interstitial edema or interstitial accumulation appears microscopically in the form of separation of the extracellular matrix elements. Taking up subcutaneous edema, it is mostly, as you have already pointed out, it is seen in the dependent regions of the body, may be encountered in congestive heart failure or in cases of renal failure and nephrotic syndrome as well. This edema, which is due to the renal abnormalities, mostly appears in the periorbital region first, because of the periorbital tissue has loose connective tissue and the fluid tends to accumulate there. But for some obscure reasons, it is seen that the edema of the congestive heart failure is mostly seen in the dependent regions initially, and the edema of the renal origin is mostly seen in the periorbital tissue. Both are actually pitting edemas. This is the pitting edema, and this one here is edema seen in the periorbital region. Okay. Edema, when it's present in the lung, and then it is known as pulmonary edema, may be encountered, as I told you, in cases of left ventricular failure, so renal failure, acute respiratory distress syndrome, pulmonary infections, etc. This pulmonary edema may be grossly, the lungs appear wet, heavy, boggy, and microscopically you can see that these are the alveolar spaces, these are the alveolar septi, and there is a lot of fluid accumulation which is appearing as clear unstained areas. These are due to a lot of fluid accumulation that is taking place in the alveolar spaces. This is again a close-up view, and here you can see these are the alveolar septi, these are the alveolar capillaries, these are congested, and the fluid moves out into these alveolar septi first and then into the alveolar spaces. So this is accumulation of excess fluid in the lung tissue, and this is known as pulmonary edema. Edema occurring in the brain may be localized or generalized depending on the various positive situations. Localized edema is seen in cases of neoplasms or certain abscess formations, whereas generalized edema is encountered in inflammation of the brain, that is encephalitis, and certain other situations. Trauma can also lead to edema of the brain tissue, trauma to the skull. Now, what is when you observe edema in the brain tissue, you will see that this is the normal brain and this is the edematous brain. What is the difference here? You can see that these gyri, they appear to be swollen in brain in cases of edema. So due to the collection of fluid, the gyri become swollen and the sulci become narrower. Obviously, there is entire enlargement of the brain with swelling of the gyri and narrowing of the sulci. So this is the gross appearance of edema seen in the brain tissue. The importance of brain edema is that there might be herniations, because you know that brain is confined to a limited space within the skull. When it increases or enlarges in size, the tissue will herniate from its normal confines, and these herniations can have adverse effects, so much so that one of the situations where the blood is where the brain is pushed out of the foramen magnum may compress the medullary area of the brain, and you know that there are vital centers present in the medullary area. Depression or compression of these vital areas like the respiratory center, etc., might lead to a fatal situation. Clinically, edema, the most important feature is that edema occurs due to some underlying disease or underlying condition like the cardiac failure, like the cirrhosis of liver or the nephrotic syndrome, etc. So it signals that there is some disease present which should be dealt with. Other clinical effects of edema is that even if it's localized, and if it might impair healing. Also, whenever there is edema, it might be a site of infection. Infections are common to occur in areas of edema, and pulmonary, in cases of pulmonary edema, accumulation of fluid within the alveolar spaces can obviously compromise breathing and even might lead to death. We have discussed the herniation situations when especially the herniation when it occurs towards the foramen magnum, then you can see this is the brain tissue, and when it enlarges, because of being present in a confined space, it moves out through the openings that it can find. One of the openings is the foramen magnum here at the base of the neck. When the brain herniates within this foramen magnum, this is the medulla, and here in the medulla I told you are the vital centers. When these vital centers are pressed upon, it might have fatal consequences. Okay, now we would summarize what is edema. It is the movement of fluid from the vasculature into the interstitial spaces with accumulation of excessive fluid in the interstitium or the body cavities being called as edema. This fluid may be of a transudate or may be an exudate and may accumulate due to increased hydrostatic pressure, decreased colloid osmotic pressure, increased vascular permeability, or lymphatic obstruction. At times, sodium and water retention, as in the cases of certain renal diseases, might also contribute. With this, we finish off with edema and we move on to the next topic, that is hyperemia and congestion. Hyperemia is basically a localized increase in the volume of blood in the capillaries and small blood vessels. It is an active process and may be encountered as you have seen that in cases of inflammation, there is increased flow of blood to that area, and there the increased flow of blood increases the volume of blood in that area, resulting in redness or rubor that we have studied. So in cases of inflammation, there may be hyperemia. Also, another example, a physiological example, is blushing. Alright, so here we can see that this is the capillary network. This is, here is the arteriolar end and here is the venular end. So there is increased amount of blood in the small blood vessels, that is the arterioles and the capillaries, so much so that most of the capillaries are contain the oxygenated blood which is coming from the arterial side, and hence this is due to increased amount of oxygenated blood. This gives a reddish color which is also seen in blushing or inflammatory conditions or even in exercise. This condition is known as hyperemia or erythema at times. It may be seen in cases of exercise, inflammation and chemical substances presence of chemical substances. Congestion is also increased amount of blood in the small blood vessels, the venules and the capillaries now. But this is a passive condition whereby the blood is not being drained by the venous system. In cases of hyperemia, the blood flow was increased from there was excessive blood in the smaller arterioles and capillaries, arterial side of the capillaries, increasing the amount of blood there, and this was an active process, whereas congestion is a passive process where the outflow of blood is somehow obstructed and the venular or deoxygenated blood accumulates in the capillary and the small vascular system. This may be seen in cases of where there is obstruction to the outflow of blood, which is more commonly seen at two places, the lung and the liver. We will consider the examples. The congestion may be alright, let's just first let me tell you that both these situations, the congestion may be acute if it develops suddenly, and it may accumulate over a longer period of time, and then it is known as a chronic type of congestion. The pulmonary congestion might also be acute and chronic, and the hepatic congestion might also be acute and chronic. In cases of acute pulmonary congestion, what do you expect to find? Obviously, there is increased amount of blood in the arterioles. And where are the arterioles present? The arterioles are present and the arteriolar capillaries are present in the septi, the alveolar septi. Hence, we can see that these are the capillaries in the alveolar septi, and these appear to be quite congested and increased in number. Obviously, when there is increase in these capillaries channels, there is increased blood within these capillary channels, there will be more hydrostatic pressure and fluid will come out into the septi first, which will become distended and thence into the alveolar spaces. With this flow of fluid out of the capillary channels, a few RBCs also migrate out of them and come into the alveolar spaces. These RBCs or the hemoglobin within the RBCs gets degraded and into hemosiderin. This hemosiderin is then taken up by this. Here you can see a macrophage. This is the altered hemoglobin of the blood of the RBCs, that is hemosiderin, and this hemosiderin pigment is picked up by the macrophages, and these macrophages are then called as the hemosiderin-laden macrophages. This here is the hemosiderin-laden macrophages. These are the alveolar septi with congested alveolar capillaries filled with RBCs. The alveolar septi are quite broadened by the accumulation of fluid, which has also come out into the alveolar spaces. And not just the fluid, but RBCs are also present within the alveolar spaces. The hemoglobin within the RBCs is released and degraded into hemosiderin. This hemosiderin is then taken up by the macrophages and converted into hemosiderin-laden macrophages. Now, what did I tell you was the most common cause of this edema fluid present in the lungs? It was left ventricular failure. So, in cases of left ventricular failure, a lot of edema fluid accumulates and RBCs come out into the alveolar spaces, and this situation happens, and these hemosiderin-laden macrophages are found. Hence, these hemosiderin-laden macrophages are common finding in left ventricular failure, and therefore that is a type of cardiac failure, and therefore these hemosiderin-laden macrophages are also called as the cardiac failure cells. So whenever you hear cardiac failure cells, don't think of any cardiac muscle cell or something, but these are actually the hemosiderin-laden macrophages found in the alveolar capillaries, found in the alveolar spaces of the lung, and since they are due to cardiac failure, therefore they are called as the cardiac failure cells. Alright, so this was about pulmonary congestion. Now, we can also consider this example of hepatic congestion. Hepatic congestion occurs when there is a blockage of the central vein for some reason. Whenever there is central vein blockage, what would happen? There would be obstruction to the drainage of blood. Within the hepatic lobule, I'm sorry, I forgot to put in a picture of the hepatic lobule, but I hope you still recall it from your histology lectures and histology knowledge, that the liver, the functional unit of the liver is the hepatic lobule, and it comprises of sinusoids running towards this. There are cords of hepatocytes with intervening sinusoids, and they run towards the central vein, which is present at the center of the lobule, and the blood which comes from the portal triad, from the hepatic artery in the portal triad, diffuses or flows through these sinusoids and drains into the central vein. If there is for some reason an obstruction to the outflow of blood from the central vein, what would happen? Then there would be accumulation of blood in the sinusoids, and with the accumulation of blood there would be, that is, the sinusoids would become congested. The congestion in the sinusoids will compromise the oxygen supply, because the periphery of the lobule may get a little bit of oxygen from the portal from the blood vessels in the hepatic artery branches in the portal triad. A little bit of oxygenation at the peripheries may be seen, but the central portions are deprived of. This is the central vein here, and the central region of the lobule becomes deprived of oxygen, and the hepatocytes here in this region, they undergo necrosis. The peripheral regions of the lobule are somewhat maintained, and they show a kind of irreversible injury in the form of fatty change, and this is because the blood flows from the portal area towards the central vein. Initially, when it starts, it has some oxygen which may be taken up by the hepatic cells or hepatocytes in the peripheral region of the lobule, but as it moves on, the oxygen is becomes deficient, and this hepatocytes towards the center of the lobule, they undergo necrosis. This type of picture is known as nutmeg liver, where there is this is the gross appearance and this is the microscopic appearance. This is the central vein. Around the central vein, there is an area of necrosis which becomes depressed when then the situation becomes chronic, and this is the hepatic lobule roughly, and the peripheral region of the lobule shows fatty change, which is an irreversible injury to the hepatocytes due to hypoxia. And the gross appearance resembles this nutmeg, and therefore this kind of situation of chronic passive congestion of the liver is known as the nutmeg liver. The liver picture is not resembles the what. Do you know what a nutmeg is? It's jaifal, which you use. It's a condiment used for cooking. You can see that this is the cross section of nutmeg, and the appearance closely resembles that of the cut surface of the liver, and hence it is the liver of chronic passive congestion is known as nutmeg liver. So this was regarding hyperemia and congestion. Hyperemia being an active process with increased amount of blood in the small vasculature, and seen in inflammatory conditions in exercise, during exercise, and congestion being again a situation where there is increased amount of blood present in the small vasculature, but in this case it is due to decreased drainage from the venous end, and therefore the blood is mostly deoxygenated, and the area appears to be dusky red in color rather than bright red. Examples of important examples where you encounter congestion are within the lung, where where the pulmonary congestion might be acute or chronic, and heart failure cells may be encountered in chronic pulmonary congestion, and these situations may be encountered in cases of left ventricular failure or left-sided cardiac failure. And then there could be acute hepatic congestion or chronic hepatic congestion depending on the duration. And then in cases I've already shown you that chronic passive congestion of the liver resembles the cut surface of liver resembles a nutmeg, and hence it is also called as the nutmeg liver. Then another term is cardiac cirrhosis. Now cardiac cirrhosis is when due to right-sided cardiac failure, the blood is not able to flow out through the central vein from the hepatic vein, that is through the central vein. There is damming up of blood, there is retention of blood, excess of blood is accumulating within the smaller vessels within the liver, and therefore we should have the situation of chronic passive congestion because of right-sided heart failure, and hence this is known as there is fibrosis later on. The necrotic central regions, they become fibrotic, and hence this is referred to as cardiac cirrhosis. Thank you very much. It was a long lecture, I know, but hopefully now that it's a recording, maybe you can just break it up and listen to it in episodes. If there is anything which needs more clarification, you are always welcome to ask questions. Thank you.